Hello, everyone, and welcome to this audio podcast. This audio podcast, as part of a laboratory inquiry, this audio podcast, as part of a Helm and BackRow, and this audio podcast as part of a Helm and Rudder. This audio podcast as part of a Storm Robotics production. In this audio podcast, and sort of the next few audio podcasts in this audio podcast series or edition, we'll look at the sort of the results in following the analysis, and the results in regards to the results according to the individual four individual cohorts. So initially, now looking at the results around the themes aligned to general practitioners or GPs. Uh, and again, where this works and this audio podcast series looking at sort of the looking at the works aligned to peer review and published works from 2023. So, in around the general practitioners, one of the initial themes was understanding of chronic kidney disease (CKD) and the perception of kidney healthcare. So there are many people who are also who do not understand, despite leaflets, what the hell CKD is and what is good for them. Um, uh, uh, Sort of wider healthcare professionals who have expertise where patients can visit or contact would be more proactive. Relating to CKD stage 2 or CKD2, GPs code it according to what has been conveyed by healthcare scientists in laboratory, but because it does not have a physical impact on patient, it only gets described as a problem in patient's notes and not much else. There are a significant number of patients who do not want to understand what CKD is and what changes are required. There are many people who also who do not understand, despite leaflets and what is good for them. A GP in around some of the ICA, if you like, the ICA around this. A GP here suggests, as others, and there will be some more sort of overview in regards to the other themes under this particular cohort. Um, that it might be advantageous to CKD patients that they have access to health professionals with specialist knowledge to help understand different disease stages and at what point treatment at what point treatment needs to be escalated. So, in regard to another theme now, looking at education in healthcare surrounding LTCs or long-term conditions. Um, so it's how bothered patients are and how much information do patients want. Having pre-printed information. I mean, there's no certain things or information leaflets in around uh, uh, information leaflets would be helpful to have a similar for CKD patients. NHS NHS, or the National Health Service, does not make collaboration easy. Community education from MDT, not just CKD but other LTCs as well. One GP perceives that in around the ICA around this, one GP perceives that the level of patient interplay is is important in terms of how much information they want. It could be suggested that the level of the interplay or interlink relates to many complexes, broader factors connected with individual curriculums, individual circumstance, demographic factors, health literacy, family, and history. A second general practitioner informs a need for patients to be provided, or healthcare service users to be provided with information, and need for sort of broader education. In around the theme regarding relating to education through technology and digital healthcare. So general concerns surrounding education, certainly many hundreds of websites for patients and professionals to choose from through Google, and where a general practitioner under this theme informed that it can be overwhelming. Um, in around some of the ICA around this, patient care necessitates an understanding health education, seeking behavior and modes of delivery to improve knowledge surrounding health and disease. Understanding here reveals that large amounts of healthcare education is available to CKD patients online. However, there is a requirement for patients to be to a requirement for patients uh, uh, to uh, to have a sense of guidance on how to navigate context appropriately to appropriately for it to be implemented. In around the theme now, the theme in regard to future roles of allied health professionals, for future roles of allied health professionals in again under the theme under the cohort in regards and relating to the general practitioners. So CKD2 and the whole pathway currently still lacking most of the time. Could be a decent channel for those who visit GP land to see sort of broader healthcare professionals. Healthcare scientists could be involved here. Smarter algorithms and sharing in around this smarter sort of links into sharing information, and MDT approach and multidisciplinary sort of team approach. Everyone has a responsibility to contribute best practice. GPs focus on acute kidney injury or AKI, and not so much CKD or chronic kidney disease. Renal consultants or clinicians coming renal clinicians on uh, uh, renal clinicians or nephrologists who go out who go out and sort of teach in GP practices about CKD has probably been the most significant development in the last decade. So in around the ICA around this, one GP suggests a need for a shared care approach in the care of CKD in the care of CKD healthcare service users, while specialists to educate non-specialist health professionals, whilst specialists are required to educate non-specialists in around non-specialist healthcare professionals, i.e., GPs, on CKD. In context, GP, the general, there's one GP informs smaller, where one GP informs sort of smaller approach to sharing information. MDT approach, everyone has has a responsibility to contribute best practice. So now in regard to another theme, screening and kidney biomarkers. So perception is unsubstantiated in primary care. The difficulty that comes is one in terms of monitoring monitoring them. Does patients' blood need a recheck? Are there any underlying causes? No, no routine monitoring, but um, so a second that was comment from comment from one general practitioner. Another comment under this theme, looking at in regard to screening and kidney biomarkers. A general practitioner informs no routine monitoring, but there are alerts on GP systems to prompt screening, and GPs can also look at renal and urine urine investigate urine and urine, for example, to provide more some sort of indication relating to CKD stage and severity. Not so much, not sorry, not so much in relating to stage and severity. However, not so much for CKD, more for acute kidney injury or AKI. So in regard to some of the ICA around this, understand reveals that there is little consistency with regards to the monitoring of CKD patients in primary care, and the GP suggests that the need for clearer guidance on monitoring CKD patients, especially relating to the severity, especially in relating to the severity. Now, in looking at another theme under with general practitioners, looking at now safety and governance. So under this theme, if GPs know that there is a patient who has got CKD or is at risk of developing CKD, or on medicine which increases the level of developing kidney insufficiency, they will play safe. It really is about patient. It really is in around patient safety. So in around the sort of ICA, ICA around this, a GP relates understanding patient safety and medication management, and there is a need to be aware of patients who may be at the risk of developing CKD due to medication use. Diagnoses and coding are important. So although not in this peer reviewed and published works from 2023, just to elaborate, that where in primary care, and in primary care more so than in secondary care, in some regard, that that on electronic on and in through electronic patient records, the one of the biggest sort of challenges retrospectively have been that GPs, when sorting to diagnose, or part of diagnosis or patient diagnoses, one of the issues, one of the sort of retrospective issues has been the coding of specific symptoms or symptomology linked to sort of this actual varying and specific diseases. So, for example, if someone in primary care presents with symptoms that linked to, for example, acute kidney injury, or can link to chronic kidney disease, or linked to, for example, symptomologies that where there could be, for example, more than two or three symptoms or symptomologies that link to a specific form of sort of urological or nephrological sort of conditions. Then the coding in the coding aligned to aligned to uh, sort of practices in primary care. Historically, this is have not always been have not always been so good. So, for example, there have been there is literature and there is evidence and works to inform that, for example, certain conditions, for example, um, uh, unless a patient presents or has particular symptomologies, then a patient or a recipient, a healthcare service user, does not directly have that condition, although directly have that condition. So, for example, if someone presents with anemia, so a low hemoglobin, and also presents with sort of a low platelet count, for example, and also a low and also sort of an abnormal PT or prothrombin time, or um, or an activated prothrombin time, APTT, for example, then the symptomology, or the hematological investigations in this regard could, for example, indicate a patient having an indication that a patient might have a form of a clotting disorder, a clotting condition. But in the in primary care, as part of primary care, the electronic records, or the way that the way the symptomologies are coded, those three sort of sort of symptomologies linked to those sort of parameters, for example, can be linked to varying sorts of conditions, or illnesses, for example. However, someone with a low hemoglobin and a low platelet count, and a low hemoglobin and a low platelet count and a low activated prothrombin time, APTT, could mean that a patient has a specific form of a hematological disease. And so one of the biggest challenges has been where GPs, where general practitioners still have not been able to code specifically, for particular illnesses or conditions in primary care, health thus making the link, the sort of integrating into where patients, for example, patients or healthcare service users who may be required referral into secondary care. It has been literature and evidence informs that there can still be challenges in that, and as part of that, sort of process, part of that sort of process. So now looking at sort of the now looking at sort of the themes